Soy Ernestina Azor, pediatra de atención primaria del Centro de Salud Virgen del Mar de Almería.
Hola, soy Valentín Pineda, soy pediatra.
Hola, soy José García Sicilia, pediatra del Hospital Infantil de La Paz de Madrid durante 43 años.
Y mi primera edición de BALMIS fue hace ahora 20 años.
Creo que he asistido a todas las jornadas invitado como ponente, excepto el año pasado por una urgencia quirúrgica. Las jornadas fueron muy interesantes desde el principio y han ido mejorando en cada edición.
Estas jornadas de vacunas, celebradas anualmente en Almería, han conseguido ser un referente nacional e internacional y creemos que necesitan una actualización continua.
Por todas las ediciones de BALMIS han habido pediatras extraordinarios de todo el mundo y hemos aprendido de ellos un montón. Es la única manera que hemos podido contactar con ellos es gracias a BALMIS.
Hemos conseguido no solo su gran calidad científica, sino que participen los ciudadanos, los niños, donde van a llegar las vacunas.
Realmente durante estos 20 años han habido un montón de anécdotas de todo tipo, anécdotas científicas y anécdotas de vida. Yo recuerdo enseñar a beber buenos vinos a nuestros amigos pediatras americanos, a enseñarles a bailar flamenco, bueno, yo no, Paco, Mercedes, Ernestina, Miguel, etcétera, Javier.
En alguna ocasión he tenido que darle un toque de pintura a alguna ponente, porque estaba un poco nerviosa. Con ello se tranquilizó y su presentación salió magnífica.
Estos 20 años de jornada son la manifestación de un éxito de Paco y quienes la acompañan, Ernestina, Belén, etcétera, y sobre todo su mujer Mercedes, su musa.
Desearos que cada año podáis venir y compartir con nosotros vuestra experiencia, porque cada año supera al anterior. Seréis bienvenidos en este 2023 y os esperamos también en el 2024.
Bueno, buenas tardes. Es para mí un privilegio y un honor presentar a la próxima ponente, a mi querida amiga y colega, la doctora Inci Yildirim. Inci es originalmente de Turquía y actualmente funge como profesora asociada en pediatría en la Universidad de Yale. Ella es especialista en enfermedades infecciosas y también vaccinóloga, con un enfoque en la respuesta inmunológica a las vacunas, sobre todo en pacientes inmunocomprometidos. Ella tiene varios roles de liderazgo dentro de la medicina académica. Dirige el Centro de Infecciones en niños de trasplantes. También es uno de los líderes en esta área del hospital y la organización St. Jude's. Y tuvo realmente un rol muy, muy importante en los ensayos clínicos de la vacuna del COVID. Fue investigadora o es investigadora del ensayo clínico de la vacuna de COVID de Novartis. Y también, tiene más de 150 publicaciones, pero creo que además de todo el honor y toda su proeza científica, una de las cosas que yo más aprecio es que es una doctora, no solamente una investigadora de mucho prestigio, sino que es clínicamente un pediatra al que yo llevaría a mis hijos. Atiende a todos pacientes por igual, atiende a cada paciente con un cuidado esmerado. Así que sin más preámbulo, quiero dejarlos con mi querida amiga, la doctora Yildirim.
All right, I need to untangle myself from these first. Okay. Thank you for the invitation. I am very happy to be here. Before I start, I have to apologize for a couple of things. One of them is the lack of my Spanish. Hola is the only word that I know. The second one is, I think my presentation will be a little bit boring after what we just had with the panel. That was wonderful. And the third one is, I apologize, it looks like I am the only speaker standing between you and the dinner, unfortunately. But I will try to make it engaged if I can. So these are the disclosures. My research is funded by NIH, CDC, and Gates Foundation. I was the PI for Moderna mRNA 1273 pediatric vaccine trial, and I also was one of the PIs for the Pfizer RSV bivalent RSV vaccine for the pregnant woman. And I have funding from industry for these efforts to my institution. And I will figure out how to move my slides. These are the objectives of my talk. I will go over the differences in vaccine-induced immune protection among those who have some underlying immunocompromising status. And then I will give you a couple of tools that we use to increase the vaccine-induced protection among those who have underlying immunocompromised status. So first, a couple of things about the healthy children and healthy individuals, about why we vaccinate and how vaccines work, because these are going to apply at some level to those who have underlying immunocompromising status. So we all know that vaccines work. That's why we vaccinate. This table is a summary of what happened to the vaccine preventable diseases that you see there before and after we started vaccination. You can see that for each of these diseases, each of these infections, we had closer to 100% reduction in the number of cases after we had the vaccine. And we had almost 100% reduction in mortality, or the number of deaths after we had the vaccines. And we have been doing some good work with some of the vaccines. This is a recent data from WHO summarizing how we have been doing with giving 3 doses of Haemophilus influenza type B vaccine globally. And you can see that the coverage rates are not perfect, and it is not fair that where you are born impacts if you're going to have your first birthday or not. Because if you are born in a country where you have around 60% vaccination coverage with one of the fundamental diseases, fundamental vaccines like Haemophilus influenza type B, it is less likely that you're going to have your first birthday compared to my daughter, who was born in New Haven and got the perfect vaccination. But anywhere that we were able to give these vaccines, as we increased the number of coverage, we were successful to limit or to reduce the number of mortality for each and every pathogen. So this is the percentage of those individuals who are not vaccinated, and this is the time on the x-axis, and this is the number of deaths. It's very clear, if you vaccinate more and more individuals, you will have less and less people dying from a vaccine-preventable disease. And it is also money-making. So if you are someone who is trying to convince the Ministry of Health, you can just put this slide in front of them and say, look, we will make at least $100 if we give Haemophilus influenza type B vaccine for each individual that we vaccinate, and we will make more than $100 if we vaccinate with Streptococcus pneumoniae. And there are estimates about, for the last 2 decades, estimates about how successful we were. We think that we saved more than 20 million people from dying because we used vaccines. And we also made money, more than 350 million US dollars. So we made money, but we also saved lives. So how do vaccines work in an otherwise healthy individual? So you get your vaccine, if it is a protein vaccine, and if it is given intramuscularly, it is delivered to your intramuscular space, and then the immune cells that we call antigen-presenting cells, who are waiting in that space, welcome the antigen that was delivered through the injection, and then they chaperone that antigen to your lymph node, the closest lymph node that you have. And then in the lymph node, you have germinal centers, where the whole magic happens after the vaccine. So the yellow circles are the germinal centers within the lymph nodes. And this is how the antigen that we injected, vaccination, comes to that lymph node. And when this antigen is within the lymph node, again, this is the lymph node, this is the germinal center, this is your bloodstream, and this is your bone marrow. The B cells within the lymph nodes meet the antigen with the help of antigen-presenting cells that brought the antigen to the lymph node. And then they change their structure and identity to become plasma cells, which are the cells that make antibodies. This is for a protein vaccine and a polysaccharide vaccine. B cells are activated for both. And then you have antibodies that are made by the plasma cells. But if the T cells are not involved, these antibodies are in less amount compared to other option, and they are not as strong fighters as the other options. So they have low affinity compared to the antibodies that you would have when you have T cells involved. And then if you have the T cells involved here, the T cells, they coordinate the B cells, and then they move into the germinal center. And this is what we want in immunocompromised individuals as well. This is what happens if you get a protein vaccine in an otherwise healthy child. And then in the germinal center, B cells, again, change their identity a tiny bit, and they make antibodies. But this time, the antibodies that these B cells are making with the help of the T cells are strong fighters. They are in higher amounts, and they have higher affinity for the antigen, meaning they will give you more protection for a longer time this time. And then some of these plasma cells go into your bloodstream with the antibodies, so you can measure antibody response, and you would have plasma cells circulating in the bloodstream. But the good thing is, some of them will go to the bone marrow. It is your survival reserve. It is the freezer that you put your plasma cells and the antibodies. In case you get exposed to the antigen one more time, they will come back. So I think we all agree that the vaccines work, they save money, but I'm pretty sure we all agree as well on that the vaccination being the most successful public health intervention, maybe only second to the clean drinking water. It doesn't matter if it is 1900, it doesn't matter if it is 2023. Still, vaccination rocks, and it is maybe only second to the clean drinking water. So what I just told you about the vaccines is the same story for those who have underlying immunocompromising status. There are some differences in this population, but the impact of the vaccine or what we want from the vaccine is the same. The immunocompromised population is unfortunately more heterogeneous than the healthy population, so we really do not know how to optimize the vaccine response in this special population. First of all, there is the primary disease. It may be inflammatory bowel disease or cancer, and there is the treatment targeting the primary disease. It may be a transplantation or immunomodulatory agent that affects the different part of your immune system. So immunocompromised individual A and B will be completely different, and their response to the vaccine will be also different. So one vaccine may not work for all immunocompromised individuals. Also, there is the time-varying factors in the same individuals. For example, there's the CD4 count in a child with HIV. That child may be completely fine with a CD4 count of 1,000, let's say, but can be very, very immunocompromised when the CD4 count is less than 100. So the need, the response for the vaccine may be completely different depending on the time that you're vaccinating that individual in front of you. There are other factors, including age, related to host, in terms of how it impacts the vaccine response, but also the dependency of the immunocompromised child in population protection or herd immunity is different. For example, if my daughter got a bone marrow transplant in New Haven, where we have 97% vaccine coverage with PCV13, she may be at a lower risk compared to another 8-year-old who got bone marrow transplantation in Karachi, where the vaccination rates are around like 60%. Or, I have some studies in Karachi. We have pertussis killing infants in Karachi. So if my daughter got the bone marrow transplant in Karachi, she would be prone to having pertussis because she won't respond to the pertussis vaccine, and she would rely on the population protection more than other child. And we also don't know how to define immunocompromised individual or child. This is what CDC uses when they want to give some guidance about how to use vaccines in this population. And they list some, transplant, some HIV, some immunosuppressive medications, including rituximab. But they say at the end, we don't know. It is the clinician who is going to decide how much immunocompromised status you have, how much immunosuppression you have. But immunosuppression is quite common, in fact. It is more common than we think. Unfortunately, we all age, and aging is the most common cause of immunosuppression. As you get older, your naive T cells get less and less. So the library, the reserve of the T cells that you can use and train to get immunity for the new vaccine goes down. That's why we are using high-dose influenza vaccine for those who are above 65, for example, to optimize the vaccine response instead of the regular standard dose influenza vaccine. So what is different with regards to vaccination in this immunocompromised population? First thing, unfortunately, the vaccine coverage rates are much more lower than the healthy individuals. This is a study showing the vaccination coverage for 4 fundamental vaccines among children who are transplant recipients. These people were in the healthcare system long enough to get organs, but they didn't get their vaccines. Look at the vaccination coverage rates here. This is a very fundamental vaccine, and we are talking about 60% vaccine coverage. We were able to give them an organ, but we couldn't vaccinate them. This is another study from Italy, more recent one. If you look at adults with solid organ transplant, and if you look at how much influenza vaccine coverage was, for one season, it is between 15% to 35%. But if you go further and look at who got 2 seasonal vaccines back to back, you're talking about like 7%. And again, we are giving them organs, or we will give them organs, but we are not giving them influenza vaccine. And for COVID-19, it is even worse. This is the first primary dose, 2-3 years ago, we were able to vaccinate them, maybe up to 80%. And then with the boosters, almost 1 in every 5 organ recipient was vaccinated with the booster against COVID-19. The second difference in this population is, lower vaccination coverage. On top of it, these individuals are at higher risk for getting the infection, getting the disease. So the rates of the vaccine-preventable diseases in this population is higher compared to otherwise healthy population. I have been working with Department of Health in Massachusetts and with Steve Pelton, who was one of my mentors for the last 2 decades. We have an ongoing IPD, invasive pneumococcal surveillance, in Massachusetts, and we know that children who have sickle cell disease, they have splenic dysfunction or asplenia, but most of them are not even on immunosuppressive drugs. They only have a spleen that is not functioning at 100%. These kids are at least 50-fold higher risk to get IPD compared to children who do not have an underlying disease. Children who have malignancies like leukemia or lymphoma, they are more than 30-fold higher risk to get IPD. And in addition, when they get IPD, they die more. So they get more infection, more disease, and then when they get the disease, they get sicker. This is adults in United States. You can see that this is a timeline on the x-axis. This is COVID-19 incidence, and this is the US cases, the blue line. The orange line, we had the Omicron, healthy, unhealthy, immunocompromised, non-immunocompromised, we all got that spike. Then non-immunocompromised individuals went back to their normal lives, but my patients who have transplant, they still have high rates of COVID-19. And the third difference, so we said lower vaccination coverage, more rate, higher rate of the infection. And the third one is when they get the infection or the disease, they get sicker. So this is a graph showing what happens among transplanted children when they get vaccine-preventable diseases. The first bar here shows among every children admitted in the US to the hospital who got transplant, 15% of those came into the hospital because they had a vaccine-preventable disease. And more than 15% of them got to the ICU, so they got sicker. And then we have roughly 2% mortality. And these infections that brought these kids to the hospital are the infections that we have the vaccines for a while. We know how to use these vaccines, like varicella vaccine, pneumococcal vaccine, or influenza vaccine. These vaccines are available. Same story with the adults. This is a study with the adults who got solid organ transplants, having sites in Spain, Canada, and US. They had roughly 600 individuals who got influenza after the transplant. And when they got influenza, 1 in every 5 cases got pneumonia. Almost 70% of those made it to the hospital because they were that sick. And 10% got to ICU. Roughly 8% got intubated. And we had 9% mortality. Again, vaccine-preventable disease. These individuals are within the healthcare system. They have been with us long enough that we gave them organs, but we couldn't give them vaccines. Another one, this is not an acute outcome, but a long-term outcome, showing that individuals who are immunocompromised, if they get HPV, they are at least 7-fold at higher risk to get cancer because of the HPV, 7-fold higher. So that makes it even more, I think, unacceptable. If you survive a disease that you needed an organ transplant, you survived the transplant with everything else, and then you're getting cancer because we couldn't vaccinate you. The fourth difference, so we said more infections, lower vaccine coverage, more severe disease. And the fourth difference is, unfortunately, when we vaccinate these individuals, the antibody levels that they have after the vaccine, they don't stay at the level that we want them to stay. At least they don't stay as long as healthy individuals. This is a study looking at what happened to hepatitis B surface antibody after transplant among those who got kidney transplant. And if you look at the levels, this is the median antibody level. We started at 134, which is quite good. We argue that if you have 10 and above, you're protected. So this was a very good level. And after transplant, within a year, it was down to 80% less than where it started. Those individuals who had higher antibody levels to start with, they were more likely to keep the antibody levels at the protective level, but still around 70% of those, even though they started very high, ended up having a non-productive level of antibody. So this means that if you check the antibody level and it is protective, it doesn't mean that you're done. You have to pay attention and you have to keep checking antibody levels maybe, unlike the otherwise healthy children. And these children, after transplant, we want them to go back to normal life. So you will see these individuals in your general pediatrics clinics, in outpatient clinics. And it is just a simple test to see if they are still protected by the way that we are describing it, and if not, giving them another vaccine. The only factor that was impacting where they are going to end was if they start very high, which is 100 and above, they were less likely to lose the antibodies at the end of the year. But if the antibody was from a natural infection, it didn't matter. So your patient who got hepatitis B when he or she was 3 years of age, then got the liver transplant, everything went normal, perfect, and you are following that individuals, and then he comes to you when he's 8 years of age, you can't think that that individual is protected because at some point he had hepatitis B infection. That doesn't work with the immunocompromised individuals. Unfortunately, aging makes it worse. So if you are older, you lose your antibodies more than your younger counterpart who got organ transplant. So aging by itself is really impacting your immune response and where you keep your immune response. But again, time since transplant is a factor to lose your protection as we measure it, which is the part that the general pediatricians, the community pediatricians, will have an impact because we don't see these individuals after they are done with us. A year, maybe 2, then I don't see them, but their pediatrician will follow them. Fifth difference in terms of the immunocompromised individuals and how their vaccine response varies. The immunomodulation targeting the immune system can impact vaccine response in almost every level. Again, this is the antigen-presenting cells. This is the T cell that will meet with the antigen so that it can coordinate the whole immune response to that vaccine. There are many immune modulators that we use for transplant and other inflammatory diseases that will impact this interaction. So your antigen-presenting cell will fail to talk with the T cell. That's one. So your innate response will not work. And then your T cell will not be able to talk with the B cells and other parts of your immune system because of the other immune modulators that we are using. That's number 2 as an insult. And then adaptive immune response, where your B cells are creating turning into plasma cells and giving you antibodies, that will also get impacted. So you lost your innate response and you lost your adaptive response as well. Here you go, the rituximab. I'm sure you all heard that if you get rituximab and then you get COVID-19 vaccine, it is basically getting a placebo almost. You don't make antibodies. And it impacts your primary vaccine response and the secondary or the booster vaccine response, unfortunately. And number 6 is the safety definition, as we heard from the other speakers today. You know, with the pregnant woman, it was the outcome of the pregnancy, prematurity, XYZ. With the transplant patients, we have a different way of describing vaccine safety. In addition to everything that we talk about the vaccines, we do worry about harming the transplant, the organ that we put in, or the bone marrow that we changed with the transplant. This happened with the H1N1 pandemic. Patients who got influenza vaccine after the bone marrow transplant, they did develop new antibodies, and then they ended up having transplant graft failure. But we had follow-up studies, and we still don't know if it is a real risk. But the way that we practice is you have higher likelihood to go into the hospital or to go to ICU or die from a vaccine-preventable disease compared to having a graft failure because you got influenza vaccine. But it is another difference for vaccination in immunocompromised population. And number 7 is these individuals are ignored for many reasons, and they are not part of the clinical trials. William Osler, who is the father of the endocarditis-related definitions, Osler, nodules, and everything. I like his definition of medicine. He says it is a science of uncertainty and art of probability. We, the ID providers for those with immunocompromising status, I think we are really rocking this because we don't have data when we practice. This includes the vaccines as well. But this is not fair for many reasons. My patients who are at higher risk for the disease, higher risk for the disease-related bad outcomes, deserve the vaccine access as much as otherwise healthy children or adults. We heard about RSV vaccine today. I am one of the PIs for the bivalent RSV vaccine. I included pregnant women in my study. The industry didn't let me do the study with my immunocompromised population. Industry will industry, and I don't have funding to run that study. This is a graph that shows that RSV, right here, we heard about it. It's an important infectious disease that kills the transplanted or immunocompromised individuals. But yet, a 60-year-old, otherwise healthy individual today can go and get the RSV vaccine. A 10-month-old, otherwise healthy infant can go and get a monoclonal antibody, that is long-acting monoclonal antibody, but I cannot use monoclonal antibody or the vaccine in anyone who has transplant as of today, because we don't have data. And we, again, reached out to those companies, and there's no interest. It won't be there. Another example of how I failed to do what I really want to do. So this individual is the first young man or individual that I consented for the mRNA 1273 vaccine. This was 5 days after the WHO called it pandemic. We handpicked him and others because he was young and he didn't have any immunocompromising status. He was not even on inhaled steroids for asthma or something. And then, we had the vaccines. I got my vaccine within 9 months as a healthcare worker. He got his vaccine a couple of months later than I got my vaccine. But my patients, again, transplanted patients, couldn't get the vaccine until the end of 2021. Like, I couldn't vaccinate them because, again, I was the PI for the mRNA vaccine study in kids and adults from phase 2 to phase 3, but I didn't have a study for my transplant patients. So we didn't know how we can use these vaccines in these individuals, if they will be responding, and if they don't respond, what we will do with them. We didn't know. We didn't know the safety. It is the same story with the RSV vaccine or the monoclonal antibody. We don't know if it is safe. We know it is needed. We don't know if it is going to work. But the safety, concerns about the safety because of lack of data will prevent me using that vaccine in my transplanted patients. But yet, we know that the vaccines give protection to these individuals. This is a cohort with influenza infection, and comparing those who got the vaccine, those who had different disease outcomes. And if you look at the pneumonia and no pneumonia group, those who did not have pneumonia were more likely to be vaccinated. The same for those who went to ICU and who did not go to ICU. Those who did not go to the ICU were more likely to get the vaccine. It works as the antivirals. We use antivirals, but we do not vaccinate our transplanted patients. Also, we know that those who got vaccinated, they have lower viral load in their respiratory tract, which is a good indicator that they will have less severe disease with the influenza infection. So, we were talking about COVID-19 vaccines and how vaccine acuity is important. This is the same thing for the transplanted immunocompromised individuals, independent from the age. It is not fair that we do not create data to use the vaccine for these special population, because then it prevents their access to the vaccines. We have tons of guidelines, European and IDSA, and we came up with some that are not really overlapping all the time. That's the other layer. Like, we don't have a clear guidance because we do not have data. But I want to mention a couple of things about how we are trying to optimize the vaccine response. Again, if you're not taking care of a transplanted patient or immunocompromised individuals, this is not what you're going to do. But these patients will end up in your office and you will follow them longer than I do. So you will have the potential to help them more than I do in your practices. So we have the response that is not optimum. We do a couple of things to make it a better vaccine response. Okay. we use some adjuvants to make the vaccine response stronger. We can increase the antigen level in the vaccine. We will do some cocoon vaccination. We can increase the vaccination and the access to the vaccines. We can use different regimens, and we can vaccinate the donors before we give the organs to the recipients. And we could do targeted surveillance, which is different from otherwise healthy individuals. So with the adjuvanted vaccines, we have some success. This is the Shingrix vaccine, the recent vaccine with the adjuvant, AS01, which is a plant-based adjuvant, and it works very well against the, it gives you a good protection against the zoster episode. It has roughly 70% efficacy for clinical zoster among those who had bone marrow transplant. It also helps with the duration of the painful episode when you get zoster. So either way, the vaccine is helpful if you have data and if you can use this vaccine in the transplanted individuals. It also works better with those who are older. It is almost like 97% efficacious with the adjuvant. One thing to remember though, this is from the older individuals and how Shingrix vaccine, the recombinant varicella zoster vaccine, gives you antibodies. So this is the blood level anti-glycoprotein E antibody, which is the targeted antigen in the vaccine. The yellow ones are the placebo. The green ones are the vaccine group. Looking at this, you could argue that the antibody levels are not really different between the placebo and the vaccinated group, but yet I just showed you that it is clinically efficacious, up to 97%. So this brings the point that maybe looking at what antibody you have circulating in your blood is not really what you should measure, especially in those who have immunocompromised underlying disease. This is the same group, this time looking at the CD4 positive T cells that are epitope specific, so specific to that antigen. And you can see that the vaccinated group really has higher CD4 counts. So the vaccine, in fact, worked. We just didn't have the tool in terms of measuring the vaccine response. This is not a clinically available assay. It is expensive, it is done in research labs, but maybe this is what we should do for those who have immunocompromising status. You could increase the antigen level. As I said, this is a study looking at what happened when they gave high-dose influenza vaccine to adults with bone marrow transplant. So instead of 15 micrograms for each strain, they gave 60 four-fold micrograms of each strain as the vaccine. And they were able to show that when they used a higher dose, at least for H3N2, they got a bit better response. And the same for the older adults. You know, when they used higher dose compared to 15 microgram of each strain, they got better vaccine response. You could also use different regimens, like you can boost influenza vaccine. With the adults, they don't do that. You know, with the younger kids, we do that. If it is the first influenza vaccine, we repeat in a month if you're younger than 9. This study was looking at what happens if you give 2 influenza vaccines per season when you have underlying organ transplant in adults. And what they showed is for the short term, seroconversion rate, it was helpful, but not for the long term. So, you know, sometimes alternative regimens do not work. We try, but it may not work. It didn't work for hepatitis A. This is something, if it worked, you would be able to do in your offices if, you know, if you had someone who had transplant. Another tool that we are investigating is if we vaccinate the donor before giving the organ, would that help with the vaccine-induced protection in the recipient? So basically, it is like we are trying to mimic the placental antibody passage. You know, you vaccinate the mom and then you think the infant will have the antibodies. This is more like transplanting the memory cells as well from the donor when they get the bone marrow. And there are studies from 2 decades ago showing that if you vaccinate donors a week before harvesting the bone marrow, and then give it to the recipient, and then you vaccinate the recipient, you have better antibody responses in the recipient for almost all serotypes, but not serotype 4, but the rest that are included in PCV7. This is of interest. My lab is working on this, but so far we couldn't mimic the results, and there have not been that many studies after the initial studies. So, but it's something that we could do in the future. We know that for some vaccines, the protein vaccines, this was shown promising, but for some vaccines, they didn't show that there was an increased response protection in the recipient. But then the argument would be, is it ethical to vaccinate the donor to protect the recipient, which is an open discussion. And the final thing that we do differently in those with immunocompromised status is we do targeted surveillance. This is a study looking at individuals with cancer in the US. And you can see that 1 out of 4 individuals with cancer is not protected against measles. And more than I think 40% of those are not protected against mumps. So it's a very easy test to do. You could check measles antibodies, you could check mumps antibodies, and it is, it's not rare. It is 1 in every 4, and you can vaccinate those individuals. So these are the vaccine preventable diseases that we have some idea of what the correlate of protection is. It is not ideal, but we have titers, and then we can define some titers being less than optimum, some titers being a little bit higher, so we are okay, and then we can vaccinate against these infections. We don't recommend this for otherwise healthy children. We don't do this as a public health service, but this is a special population where you can do targeted surveillance. And then we can do cocoon vaccination. As pediatricians, we know that if you vaccinate the mom, the teenager brother, and the grandparents in the household when you have an infant, it is cost effective and it provides extra protection for the infant until they have their own immune system ready to respond to the vaccines within the first 6 weeks, for example, of life. This is a slide basically saying if you do the cocoon vaccination in addition to infant vaccination, you again have a very cost-effective intervention. However, if you go and ask to us, healthcare workers, about cocoon vaccination, the answer that you will get usually would be, I do infection prevention, I do mask, I do gloves. They don't really believe in cocoon vaccination, which is sad. And if you look at the rates of the vaccinated individuals in the household among those who have underlying immunosuppressive state, look at the rates. This is for inflammatory bowel disease adults who are on immunomodulator treatment, and these are the vaccination rates for their household. And even for influenza, it is like 10% of the household members were vaccinated against influenza. And pneumococcal vaccine is around like 30 to 40%. So we do not vaccinate the family for sure, also the patient in front of us. Another intervention that we tried to increase vaccination rates among those who had underlying immunosuppressive disease was including pharmacists in our vaccination algorithms. We had the pharmacist in our hospital to review all the charts before the patients showed up in the clinic, and then they placed the vaccination orders. And we were able to get almost 100% higher influenza vaccination rates in a shorter time during the season that we were having that intervention. So this is something that you could include as well. Take-home messages from everything that I tried to share with you is, our patients who have underlying immunocompromised status are at higher risk of infection, and they are at higher risk of severe disease when they have the infection. And vaccines, again, do not save lives. Vaccination does. And we are not really doing the best that we can do with vaccinating our patients. And we know that our immunocompromised children, kids, adults, may have a reduced vaccine response when we vaccinate them, but it is still efficacious clinically. We do not know how to measure the vaccine response, so we may need to talk about cell-mediated immune response assays being available in the clinics that take care of immunocompromised patients. That's all I have. Thank you.
¿Alguien quiere hacer una pregunta o dos? Ya, Marieta.
Ah, ¿verdad? Yo tengo. I have a microphone. I'm going to say it in English and then repeat it in Spanish. My collaborator, Ann Gershon at Columbia University I believe in the 1990s or 1980s, was able to do a study of varicella vaccine in children with leukemia. Was that advocacy, or was it that things have changed and now with medical malpractice, nobody wants to do these studies? La pregunta es que en los 1999, una de nuestras colaboradoras, la doctora Ann Gershon de la Universidad de Columbia, hizo un ensayo clínico de niños con leucemia, en el que demostró que la vacuna de la varicela se le podía dar a niños con leucemia, que están inmunocomprometidos. Entonces yo me pregunto si eso fue pues por abogacía de la doctora Gershon y sus colaboradores, o es que simplemente hoy en día con la impericia médica las leyes han cambiado.
So we, post-transplant specifically, we start vaccinating around like 3 months after you get an organ with the non-live vaccines. If it is the season and there is an influenza rate high out there, we could give flu vaccine as soon as a month after transplant. And these are all the concerns about the efficacy more than the safety. Until recently, the ID providers or the transplant providers were hesitant to touch to the live vaccines. So you could have an organ that you got 10 years ago, but nobody would give you varicella vaccine. And even if you were vaccinated before the organ transplant, you would still lose that serology response. And in US, we have measles outbreaks. I don't know how Spain is doing. Since we have vaccine hesitancy, we have pockets of measles outbreaks, and my patients are getting measles and they are not doing well. Last week, we had the first study since that Columbia study that came out, and we in the US were able to vaccinate roughly 300 kids from 18 different centers with MMR and varicella vaccine after their transplant. There were 5 varicella cases that responded quite well to the antivirals after the vaccination, but the other, let's say 295 did completely well with a nice vaccine response. So the answer is, I think we should get more comfortable with using live vaccines. It wouldn't be the first vaccine that I give after a high dose of methylprednisolone, but I think there's a room, and as we have more data, again, access to the vaccines, access to the data, we should be able to provide measles vaccine, varicella vaccine.
Okay. Thank you very much. Vamos.